Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. You're in a hospital. There's a whirlwind of people in scrubs and white coats. It can be confusing trying to figure out who's who. Is that person a nurse, a respiratory therapist, a medical student, a senior doctor? Who's actually in charge? In today's episode of Mapping Healthcare, we're looking at something that sounds simple but can actually be quite complicated in hospitals. Knowing who is actually treating you. And this isn't just something patients feel. It's a real challenge inside the hospital too. And then, on top of all of that, there's this complex hierarchy of medical training. After you finish med school, you're an intern, then you become a resident, then maybe a fellow, and finally, you're an attending physician, the person overseeing the healthcare team. For anyone outside of medicine, it's like learning a whole new language. A patient describes spending a week in the hospital for a lung infection, and despite seeing a steady march of people in white coats, he never actually figured out who his doctor was. In one research study, pretty much all patients said it was very important for them to know their doctor's level of training. But even when patients think they know the roles, they're often completely wrong. A third of patients thought that a resident who is still a doctor in training needs no supervision at all. And another third of them thought that the attending physician, usually the most senior doctor in the room, is someone who actually needs supervision. It's a real problem because while those in the medical field understand the hierarchy, for patients, those roles are often totally opaque. It's not just an identity crisis, there are serious patient safety concerns here. Hospital certification bodies actually require trainees to tell patients exactly what their roles are. If a patient doesn't know who's who, it can lead to frustration, decreased satisfaction, and could even affect their ability to give informed consent if they think they're talking to an attending physician when they're actually talking to a trainee. So why is it so hard? Are clinicians just not introducing themselves? That could be part of it. I read about a study that showed that many physicians didn't specify their training level when they introduced themselves to patients. Residents introduced themselves as just doctor 80% of the time, but less than 10% actually identified themselves as a resident doctor. It's almost like a hidden curriculum where trainees sometimes seem to be afraid that if they're too honest about being a learner, the patient might not trust them. Our guest in today's episode of Mapping Healthcare is Helen Haskell, who is the president of the nonprofit patient safety organization, Mothers Against Medical Error. Since the medical error death of her young son, Louis, Helen has devoted herself to healthcare safety and quality in a variety of fields, including patient engagement, patient narrative, medical error prevention, and respectful response to adverse events. We talk about Helen's efforts in helping formulate policies where clinical staff and learners wear name badges clearly stating their names and their jobs in terms that the average person can understand. The views expressed on the show are mine and those of my guests. So Helen, welcome to Mapping Healthcare. You're a mother of two and a former archaeologist. And in the year 2000, an elective surgical procedure for your 15-year-old son, Louis, changed your life forever. Tell us a little bit about this experience to set the stage for our discussion.
I will try. It's not always easy talking about this. Even though it has now been 25 years, Louis would be 40 years old last year. But anyway, Louis was a very high-performing boy. He was the highest-scoring student in our area in South Carolina. We just thought he was the most wonderful boy in the world. And when he was 15, we took him to a major teaching hospital for what was then a new operation, a minimally invasive repair for pectus excavatum, which is a condition in which the breastbone doesn't grow straight, leading to a sort of concave appearance to the chest. It's primarily a cosmetic operation, and as far as we know, the surgery went okay. But as often the case, the problems were in the postoperative care. So Lewis was not urinating, and the resident in charge of his care ordered extremely low fluids, more appropriate for a small child than for a dehydrated teenager. And the upshot was that for most of his 4 days in the hospital, Lewis was not urinating. He was throwing up, he was not drinking, he was not eating, and he was sweating profusely and not urinating. He had been given an NSAID medication called ketorolac, which is very commonly used, especially in the US, along with other painkillers. And again, the final result was that on the fourth day, he went into cardiac arrest after his caregivers really had not paid any attention to his, what to us was really obvious deterioration. He went into cardiac arrest. No one could understand what had happened. And it turned out that he had a perforated ulcer caused by this NSAID painkiller, which he had overdosed on because it was accumulating in his body. So that was the story. And it was really a horrifying experience. We took a healthy child into the hospital for elective surgery, and he came out dead. I didn't know what had happened, but I knew that Lewis had not died a natural death. There wasn't any way I could let that rest. The day after his funeral, I started writing down my recollections of our experience in the hospital. And then I began calling everyone I knew to help me answer my questions. So it didn't take me long to pinpoint ketorolac as the cause of the perforated ulcer and to learn the risk of the pectus surgery that Lewis had had, which had been painted as sort of minimally invasive and very safe, which it really wasn't. But the thing that really galvanized me was the overall dysfunction of the healthcare delivery system that I was learning about. Everything that had happened to Lewis seemed to me to be a predictable outcome of the healthcare system, especially of an academic medical system. I was just driven by guilt for my own ignorance in putting him in that situation and not knowing how to help him. And my work to improve that system was the only thing I could still do for him. It was all I could think about. I dropped everything and became a patient safety advocate.
That experience, as you mentioned, led you to get involved in patient safety efforts in education as well. So your son Lewis's story has been featured in educational programs and videos used in medical schools and nursing schools across the country. I myself use it in training clinicians at my health system. And Lewis, basically, as you mentioned, died from a failure to rescue from a side effect of a medication. And you described the staffing situation during Lewis's hospitalization when I've heard you speak in some of the videos that are out there. How did you believe the staffing situation affected his outcome? What were some specific barriers your families faced in obtaining the care you needed in the hospital as a result of this?
You know, there were so many aspects to what happened to Lewis, which I think when you have a fatal medical error that's really common, it is often a snowball effect of a lot of little errors and people just not recognizing what's going on. But as I went through it, the process of investigating, and I was really the only one who thoroughly investigated my son's death. I don't think left to the healthcare system they would ever have determined what had happened. And as I went through it, I could just only describe it as peeling an onion. Underneath every problem, there was a deeper problem. But while Lewis was in the hospital, there were two aspects that really took me aback. One was the fragmentation of the system, and the other was really the sort of general lack of expertise of many of the individuals, most of the individuals involved, not knowing what they needed to know. So everyone involved in Lewis's care seemed to be simply performing a task. My impression was that they didn't always know why they were performing that task, but I think they had confidence that they were feeding something into a larger system that someone much higher up was overseeing. I certainly thought that too. And when I finally got Lewis's records after he died, I tore into them, trying to figure out who was supposed to be in charge. And the answer was that no one was in charge. It was simply a machine going round and round without necessarily paying attention as to why it was there. No one was looking at the data they were collecting, they were just collecting it. Everyone was finding excuses for the things that didn't seem normal, such as assuming without looking that improper readings were equipment malfunctions. On the morning that Lewis died, when he had no detectable blood pressure for 4 hours, the nurses and the interns spent that time looking for new blood pressure cuffs and machines, rather than calling a code when it could have saved him. They took his blood pressure about 12 times with 7 different implements and ended just a few minutes before he coded.
So clearly, the lack of transparency in the staffing system, who's a physician, who's a nurse, who's a trainee, created problems here. And it's unfortunately still a common issue in academic health centers that patients experience this confusion, right? Like, so we aren't transparent about whose job is what and what our status in the hospital hierarchy, so to speak, is. And Lewis's crisis, additionally, an observation that was made is it developed on the weekend. So tell us why that's important for us to know.
Night and weekend care has been a big issue for us from the beginning. I was shocked at how quiet the hospital became on the weekend. What you have is low staffing and staff who are not familiar with the unit they're on or with the patient population they're serving. Almost none of the nurses involved, and certainly none of the residents, had had any real experience in pediatric. So we had scheduled Lewis's operation for Thursday, not realizing that meant he would be in hospital over the weekend and then the staffing would therefore be inadequate. And most people assume that because patient needs don't diminish over the weekend, patient care won't change over the weekend, but it does. And the same thing applies to night care. There's often a big uptick in the number of adverse events reported when the regular shift comes on in the morning and realizes the problems that have developed while they were out. So that's always been an issue, and it has never been properly addressed. I think they tried in the UK, and there was a big pushback because they wanted residents to do more work without more remuneration, which I can see would also be a problem.
Yeah, so the weekend effect, and there's variation by months as well, based on
Mm.
when trainees come in and when they graduate, on the adverse events and problems that we see in academic health centers. So this experience really changed your life, and you founded Mothers Against Medical Errors with other patients, and then you served as the president of Consumers Advancing Patient Safety. And these groups have helped do so many things. They've helped pass laws, formulate policies, and organize patients all over the world. And one of those critical pieces of legislation is the Lewis-Blackman Act. So tell us a little bit about that act.
The Lewis-Blackman Act is a South Carolina law. It basically had 4 components, and it was really the first thing we did after Lewis's death, after we had, settled his case. And the hospitals, all the hospitals, in fact, in South Carolina worked with us, including the hospital where Lewis had died. The 4 components of the act, the first was identification of healthcare workers. They're identified by name, job, and trainee status, and I don't think that's done in any other state. But that was because when we had asked for an attending physician to come see Lewis, we got a resident. And we assumed this young man was the attending we'd asked for. He didn't indicate otherwise, and we had no way of knowing. But that was a turning point in Lewis's trajectory because the resident was simply following what the nurse had said, that Lewis was anxious and didn't recognize his obvious deterioration. The second component was that patients and families should be given a way to speak directly to their physicians while they were in the hospital and not have their concerns filtered through a third party, which was, again, the problem. that we had had with Lewis and the nurses who were convinced that he had an ileus, just a reaction to opiates, which he was also taking. And the third component was that patients be given information about the role of trainees in the hospital, which is much greater than most patients and families think. So they need to know about that. And the fourth component, and this was the one that was most important to me, was that families be given an emergency number to call for help if they felt a patient's condition was serious and was not being addressed. We didn't have the term rapid response team in those days, but that's what we were trying to achieve. The irony in Lewis's case was that the attending who was not called to respond to Lewis was also a critical care doctor and was actually trying to set up such a team. But, the system mitigated against residents calling for help.
Yeah, and a lot has happened since then, Helen. And I'm an attending pediatrician now and have a badge that clearly says that I'm a doctor, and the person working with me has a badge that clearly says they're a resident. And we have rapid response teams in hospitals now. But as you mentioned, that was not the case many years ago. And even now, there are health systems struggling with these issues. I remember being a second year pediatric resident in New York back in 1999 when the To Earth's Human Report was published by the Institute of Medicine, and that exposed the high rate of preventable medical errors in the United States. And the report revealed that, there's tens of thousands of deaths annually in the US. It called for a comprehensive overhaul of the system to improve patient safety and really made it a national focus to try to improve reporting and learning from these issues. So, healthcare has come a long way in our mindset around patient safety since the Earth to Human report. However, new problems just keep coming up. So, in your mind, what's the most challenging part of working in patient safety these days?
I think undoubtedly it is the corporate consolidation of healthcare. I know that that is a real pain point for most healthcare practitioners, and it certainly is for patients. Modern healthcare has always suffered from fragmentation and diffusion of responsibility. This is the same problem I was talking about earlier in reference to Lewis. Lewis's doctors were wonderful after he died, but as kind as they were, it doesn't do much good to fall on your sword if you're not there when you're needed. And the system, as I said, just mitigated against their being there. And that's even worse now, as health systems are just being squeezed for profit and decisions are made further and further from the patient. There's some things that can only be effective if they're done in a very personal manner. And healthcare is one of them. All the algorithms in the world, I don't think, can change that. That's what we're trying to deal with right now. And it's an uphill battle. While patient engagement has become much more widely accepted, actual personal care has not.
And, the problems that we just discussed aren't limited to the US, they're a worldwide issue. And I've had the good fortune of working alongside you on a committee related to patient safety affiliated with ISQA, the International Society for Quality and Healthcare. So you and I, connected there. So, Helen, you're a former co chair of the World Health Organization's Patient for Patient Safety group. And this is a program that engages patients and families and facilitates their partnership with healthcare professionals and with policymakers. So let's look at this issue from a global viewpoint. What's the patient safety challenge in your mind that's relevant globally, regardless of geography or culture?
To me, the two biggest challenges are infection prevention and failure to rescue. I think to me, these are basic problems that can be addressed in any setting. They don't require a lot of resources, but they do require vigilance and knowledge and motivation. But, this is knowledge that can be taught. People may know about hand hygiene. I think they need to know more because often even in high income countries, they don't really understand the importance of environmental cleanliness, like catheter bags shouldn't be on the floor or cell phones need to be cleaned. There's not a holistic understanding of how infection works. And I see the same thing in critical care. I mean, most people, including many healthcare providers, still don't understand the significance of basic vital signs or signs of deterioration. And again, patients and families can be part of that. Education of patients and families to know when a patient is in trouble is a major goal for me. And yeah, there is a website that I particularly like on this. It's called EECC Global. One of the E's is for emergency and CC is critical care. I forget what the other E is, but it's basically sort of teaching basic critical care skills, information to healthcare providers with a lot of feedback from patients. And I think that's what's needed.
So, Helen, you spoke about specific patient safety challenges relevant globally, regardless of where we live in the world. So, to follow up on that, what do you think are some ways of tackling this worldwide challenge?
I think the global challenge is very interesting. WHO, in my opinion, has made serious inroads in patient safety with its programs in recent years. I see an interest in safety in low and middle income countries that really is no longer matched in upper income countries. I think the patient safety movement's been going on in high income countries for a long time without much change in safety, and healthcare providers are weary. But on the other hand, people in the healthcare world at the same time believe that they are a lot safer than they are. And I attribute this to the fragmentation of the system. Everywhere, healthcare, I think, is fragmented. And everyone sees his or her own little piece of the system. And often they don't even know the outcomes of their own patients. And until they become patients themselves, people don't realize the risk and the harm that can occur when they're not there. I think there is a self-satisfaction that works against patient safety that we need to work on. So I think the first step in tackling patient safety challenge is awareness. I mean, people need data. They need facts, they need information, and they need to see what's happening in their own institutions and offices, and often they're sort of blind to that. The public needs to be part of it. I mean, patients and families are the only ones who know the patient experience as a whole, and I don't think we'll make progress until their knowledge and experience are part of the equation.
Helen, your goal since Lewis's death has been to increase patients' contributions to safety and quality in healthcare. So, looking back at your decades of untiring work in this area, what accomplishment are you most proud of in this area since you embarked on this effort?
I think we've made a lot of progress in patient and family engagement in the past 25 years. I mean, for me personally, I think I'm most proud of the advances we've been able to make in family escalation of care in hospitals, including patient activation and rapid response. I mean, when I began this story and this journey, rather, in 2000, the only thing that the patient safety movement really wanted from us was our stories of harm. They really didn't recognize that our opinions and our knowledge of the healthcare system really mattered. And I think that's changed, at least in the US and some other countries that I'm familiar with. And I'm really hopeful that if it can change in those countries, it can change in all of them.
And that's a hopeful note, Helen. And I think the global spread of the awareness that patients are partners in identifying areas for improvement. And clearly, this deep partnership leads to long lasting changes in patient safety. So I really am so grateful for your leadership and work in this area and your devotion to the cause of making healthcare better and safer for the people that we serve. And so, Helen, to wrap up each episode of Mapping Healthcare, we talk a little bit about the place our guest comes from. You live in Columbia, South Carolina, where you've been a leading patient safety advocate. Tell us about a couple of places or activities in South Carolina that hold a special place in your heart.
It's a very small state, and it's a beautiful state with quite a lot of geographic diversity in a very small area. I went to boarding school when I was a young person in Charleston on the coast, and I came back to Columbia, which is the state capital, when I was a young archaeologist. I was working for the state doing archaeology. It's a beautiful state, and it's drenched in history as much as any place in the U.S. is drenched in history. I know it doesn't compare to some other countries, but some of our history is pretty fraught, right? And I think, in my state, I think we have learned to live with it and to see the common ties that we all have, which is something that outsiders don't always appreciate. It's a state full of hospitality and courtesy and forgiveness, and I think it's something we could all learn from in life and in healthcare.
Yeah, that's well said, Helen. Common ties, courtesy, consideration, that really is at the core of everything that we do in healthcare, right? And this partnership that you've helped build with patients and healthcare systems just really clearly shows the value of this work. So I really appreciate your time as well as your untiring dedication and devotion to this cause that has made healthcare better and safer for all of us. Thank you, Helen.
Thank you very much. I have appreciated and enjoyed our conversation.
So that was Helen Haskell telling us about her decades of work in healthcare that has made a long-standing difference. Each of us very likely experienced its benefits directly as a patient. She helped formulate policies where clinical staff and learners wear identification badges, clearly stating their names and their jobs in a health system, in terms that the average person can understand. She worked on an act that requires teaching hospitals to give patients written information about the role of trainees and students in their care. Because of her work, many hospitals now use tags that hang right behind a hospital ID badge and clearly spell out the person's role, like doctor, nurse, resident, or intern. These badge buddies are a low-cost and straightforward way to help make patients and the medical team aware of who's who in a hospital. These simple tags also had another positive effect. They reduced workplace bias. Women physicians and clinicians of color get hit the hardest with people wrongly identifying their role or their level of training. When hospitals introduced the doctor badges, female residents saw a massive drop in the likelihood of them being misidentified as a non-physician. The next time you're in a hospital and feel like the revolving door of people in scrubs or white coats just keeps spinning, take a look at the person's badge or badge tag. Ask for names, and don't be afraid to ask, what exactly is your role on my team? If you're unwell, you want someone who listens. But if that person can't actually sign your prescription, you should probably know that too. And for me and all the other clinicians out there, we need to remember to tell our patients not just our names, but also what our job on the healthcare team is, in non-medical terms, before we take care of them. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with the show on Instagram at Mapping Healthcare if you'd like to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts.